Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Patrick Kane. Dr. Kane and I are going to be discussing meniscus repairs in detail. So, what is the difference between an all inside versus an inside out meniscus repair? When might a surgeon use one over the other? When might outside in technique be used? And so on that way. So, we discuss a lot of the more intricate details of surgical repair, and we also discuss some rehab applications as well. So really great episode, real deep dive into the meniscus. So this episode and every episode in season 5 is brought to you by Isophit, our go-to for all things isometric training. For more, you can check the description below. Enjoy. Dr. Kane, welcome to the podcast. I'm super excited to work with you today, man. Thanks for being here.
Yeah, thanks for having me. Appreciate it.
For people who might not be familiar with you or all the amazing stuff that you're doing down in Southern Delaware, would you mind filling them in a little bit about who you are and what you do?
Sure. So I'm an orthopedic sports medicine specialist down here by way of Vail, Colorado for fellowship and Rothman Institute and Jefferson for residency. Yeah, I guess this is a national broadcast or podcast. So we're in Rehoboth Beach or Lewis, Delaware. So tiny beach town. But yeah, my practice, even down here, though, is pretty much strictly sports. So probably 60-40 knee shoulder. So kind of a little bit more knee heavy. But yeah, we're a small state down here in Delaware, but it's pretty awesome. Right at the beach. It might get a little bit more notoriety because President Biden comes here in the summer, but it's a pretty good spot.
Yeah, definitely. And I'd like to say that you're pretty darn good at what you do. I mean, the names of the places you trained at alone should catch some eyes. But I've seen some work from your post-op, and I've seen some conservative management patients from you, and everyone has had nothing but great things to say about you. And one of the things I think I saw initially from you was actually someone following a meniscus surgery. And the meniscus injuries have always really fascinated me. They're fairly common, but they can be very complex and come in a variety of different flavors, so to speak. Would you mind kind of breaking down for people just the overview of like the anatomical considerations of the meniscus and how meniscus injuries occur in the first place?
Yeah, meniscus, you kind of hit the nail on the head. It is so much variety, and I think that's in a way I kind of like that. ACL injuries, it's kind of tore, not tore, and they're very, very common. A lot of people know about the ACL, but meniscus tears, they come in all different shapes and sizes, all different ages, and there's definitely differences between tear patterns and who gets what type of tear, but it's really all across the board. So just kind of from a 30,000-foot view, meniscus, they're little cushion pads in your knee. You have two of them. They're kind of like C-shaped looking discs in between the femur and the tibia. And they're really there for a bunch of reasons. The main one is chondral protection, or they absorb a lot of load. I kind of describe them as honestly like our shock absorbers in our knee, kind of like a car. They do have some other functions, such as helping to support the ACL, going back to that, particularly the posterior horn or the medial meniscus. And they have some important implications, and they kind of all play off of each other. And a lot of times some structures can get injured in conjunction with an ACL tear, particularly lateral meniscus. It's a little bit more common. And a lot of times you'll see that at the time of surgery to go in and fix an ACL. Lateral meniscal tears, particularly in the young athlete, we see a lot of that with ACL tears. But medial meniscus tears too. There's a specific part of the medial meniscus in the very, very back that we see. It's called a ramp lesion. It's kind of where the meniscus attaches to what's called our knee joint capsule. That can kind of get a tear in it when we see an ACL tear too. But, that's, again, just related to the ACL literature. But people come in all the time with different types of meniscus tears. They can happen anywhere from the young athletes to even we see them a ton in the older population too. So, those are a little bit more sometimes degenerative type meniscal tears. But we definitely get a lot of acute tears. A lot of times it'll be sometimes patients will hear a pop, or a lot of times they'll be squatting, they'll twist, and then feel pain really on the inner or outer part of their knee, depending on which meniscus was injured. And I think you may have a podcast a little bit in the past about physical exam and like MRI and all that stuff. So I won't really belabor the point with that, but a lot of overlap with ACL injuries. It's just knee pain, a lot of swelling, and pain right at that joint line, and we kind of get suspicious about a meniscus tear.
The nail on the head there, Dr. Kane, is they come in a lot of different flavors, like we said. I like how you broke it down as like almost like acute versus degenerative, because I think we tend to treat those quite differently. And when it comes to tear types or tear patterns, the way I always learned it too was you can have like a longitudinal or vertical tear, And if it tears enough, it progresses into what's called like a bucket handle tear of the meniscus. You can also have like a little radial tear into the meniscus and then little horizontal flap tears. At least those have been the most common ones I've seen clinically. Do you kind of classify them similarly?
Yeah, absolutely. So again, the classification for meniscal tears, it's really like you said, it's more descriptive. So
Yep.
in other areas of the body, ankle sprains, ligament tears, we kind of grade them on, in general, grades 1, 2, or 3, depending on if it's partial tear or full tear. These we don't really do that. It's really more how you described it. It's really more descriptive and a firsthand look at what the tear pattern is. So yeah, there's longitudinal tears, and a picture's worth 1,000 words. So I know we don't have the picture up, but easy to kind of Google it real quick. But yeah, longitudinal, there's the horizontal tears, which traditionally in the past have been, I don't want to say ignored, but they're a little bit more of a degenerative type tear. But now we've also added, like you alluded to, radial type tears. There's a specific type of tear called a root tear, which is where the meniscus actually anchors or attaches to the bone. So I think as time goes on, we're becoming more aware of the different tear patterns. And some in the past, there's a saying, you may not have seen it, but it's seen you. So they've always been there. We're just getting better at describing them and how that relates to treatment and how we can fix them surgically too.
Before we get into how we fix them surgically, there's different zones of the meniscus too. There's some that we describe as like red, red or white, white. To someone who might not be familiar with those terms, what do those terms mean, and what does that mean, like in anatomical consideration to the meniscus?
Yeah, so actually one of the classic studies back in the 80s is it came from the veterinary literature actually, where they have a really classic slide where they cut the meniscus in half after they did a vascularity study. So they injected, I don't even know what it is, some dye that they inject into a sheep or something, but they could really map out where the blood flow to the meniscus comes from. And that's where this idea or concept of white zone versus red zone and red-white zone comes in. So we kind of divide the meniscus up. Again, it's a C-shaped structure. The inner third or inner margin of the meniscus is typically classified white because the blood flow really doesn't get there. That area gets more of its nutrition from diffusion from the synovial fluid. But as you go out towards the periphery where the blood vessels are, that's why we call that a little bit more red because it has better vascularity. In general, and in the past, we've typically not had great success fixing tears that are avascular in the white zone, and we've been a little bit more aggressive at treating tears in the red zone because we think the blood is going to be there and the blood supply is there so it can heal. I think we're trying to push the envelope a little bit as technology improves, and it's a little bit controversial, but we can add some biologics to, the repairs and stuff that we'll get into. But in general, that's where that kind of concept of red versus red-white versus white comes from. And it goes again in decreasing order of vascularity as you go from out to in, where it doesn't have any blood flow.
Right, and correct me if I'm wrong, but the other piece to that too is the neural input to the meniscus as well. That's why we say like red or white is one is in relation to the vascularity and one is in relation to the neural input. And while I don't have a study to reference or a research article, from the patients I've seen pre-op to post-op, I've noticed a trend where tears in the red zones or red-white zones seem to hurt more or cause more pain for the patient than those in the white zones. And I'm suspicious if that's the neural input side of it or if it's just some other factor, but that's just one of those little trends that I've started to notice amongst patients.
Yeah, no, I agree. I think anecdotally the same. I've seen that too. Sometimes people come in and we'll call them an incidental finding. They'll have a really tiny inner margin white zone tear that they never even felt. We're getting it for some other reason in their knee, like they ripped their quad tendon or something like that, and they didn't even know they have a little tear because it doesn't hurt. But I agree with you. I think some more that are towards the periphery and are usually then also involve more tissue because it's just more tissue out there. I think they tend to hurt a little bit more too.
Yeah, no, definitely. I love that point. You mentioned before about root and different locations of the meniscus. We just think about all the different soft tissue and all the other structures really in the different areas of the knee, right? Like if I have a posterior oriented lateral meniscus tear, like we have some hamstring out there, we have ITB out there and lateral retinacula. We have a little bit of lateral gastroc. Like there is so much stuff crammed into that back corner, like posterior lateral corner of the knee that, sometimes we often forget like just how many things are going on there.
Yeah, no, I agree. It's busy. It's a lot of real estate, but important. All those structures are super important.
Definitely. And, while there's a lot of different stuff, for lack of a better way to put it, around the knee, I've noticed that there's been a lot of advancements over the past several years as far as how meniscus surgeries are performed. And, I've seen several that have been done arthroscopically where you can barely even tell they had incisions because they're so small. It's amazing what you can do through the arthroscopic tools. How do you go about doing your meniscus surgery from the scopes? Do you do just the traditional 2 incision on the front? How do you go about making those incisions, and what kind of tools and instrumentation are you generally using?
Sure. So that's a big question to answer. So I think to take a big picture look at it, I think for maybe some, people joining us with this podcast, I think you kind of compare apples to apples. A lot of patients come in, they'll tell me they had a meniscus repair. So I think first clarifying what meniscus surgery, what we do. So I think, far and away for the long time, a lot of knee scopes were partial meniscectomies, which is different. That's where we go in and we don't do any repairs. We trim up the meniscus. You don't really have to be non-weight bearing for a prolonged period of time. You're pretty quick recovery, but we're not saving the meniscal tissue and we're taking it out. And, for some tears, that's what we need to do, but we're talking, I think, a little bit more focusing on meniscal repair. So there's a big push to try to save the meniscus. Again, we talked about its chondral protection properties and how important it is for the knee health overall. So, not everybody's a candidate for meniscus repair. There's all different types of tear patterns, shapes, sizes, and it also depends what the status of the knee is in terms of the articular cartilage and what else is going on with the knee. But, when we're talking about doing meniscal repairs, there are so many different ways to do that. And again, repairing it, we're trying to save it, stitch it back together. The tear pattern dictates how you do it. It's not a one-size-fits-all approach. And I think, if you try to fix all of them the same way, I don't think you're doing them justice because there's so many different ways to repair them. And it really is dictated on what type of tear it is. A root tear, we're going to fix that differently. Typically we're doing that through a transtibial tunnel, meaning kind of re-anchoring that meniscal root back down to the tibia. Versus, yes, a small peripheral longitudinal tear in the posterior horn, that might be amenable to what we call an all-inside technique, where we kind of just fix it through those 2 incisions, through the 2 portals in the arthroscope. But a huge bucket handle tear, I still think sometimes the gold standard of the inside-out technique, where we are able to put a lot of sutures, a lot of points of fixation, is the better way to go. So I think, to answer your question, how do you repair them? I think that might be how, we're going to answer that through this whole podcast, but there's so many different ways. And I think you have to have, I call it a meniscal repair toolbox. So you have to have a bunch of different tools available for you to fix the tear based on what the tear pattern dictates and how you can get a best repair done. I think to break it down again, we kind of talked about the difference between partial meniscectomy, where we're just trimming it, we're focusing on repair. In general, the 3 main ways to do a meniscal repair are considered, it's basically how you fix it. So there's all inside, where you do it through those 2 incisions, and everything, all the work's done through those 2, or maybe a couple accessory ones here or there, but all the work is done in the knee. The inside out approach, which I alluded to before, that's been traditionally considered the gold standard. It's been around a little bit longer, but we basically fix that meniscus, putting sutures or fixation device from the inside of the knee and pushing it towards the outside of the knee. They require additional incisions either on the inside part of the knee if we're fixing the medial meniscus, or on the outside part of the knee if we're fixing the lateral meniscus. Because for those, we have to watch what we call the neurovascular structure. So on the medial side of the knee, we have to be careful of the saphenous nerve and vein, and we have to put literally a spoon retractor or whatever retractor the surgeon prefers. But I typically actually just use a big soup spoon, and that's what most of us use, to be honest with you. But you have to make an incision so you protect those neurovascular structures, and you have to have a safety incision. On the lateral side, we're worried about the peroneal nerve. If you hit that with sutures or a needle, you can get a foot drop, which is not a good day. So you have to make that safety incision on the outside to protect that. So again, that's the inside out approach. It's been around probably since the 80s, and that's still kind of to this day in the sports world considered the gold standard for like really difficult and most tears. The third way to fix it is called outside in. So now instead of going from inside the knee to out, we're flipping it around. We're going from the outside of the knee to the inside of the knee. That's typically done for tears in the anterior third of the meniscus. That's a little bit of a harder angle to get to if you're doing it with all inside devices or even inside out devices. There are a couple tools or tricks on the market now where we can hit those anterior tears with inside out techniques. But traditionally in the past, the outside in approach has been done for the tears in that anterior third of the meniscus. So again, I know we kind of divide the meniscus up into a lot of thirds. We talked red, white. We're not talking about it in that plane. That's kind of looking at it in a cross section. We're looking at it now instead of from the back of the knee, we're looking at the anterior third.
I love that. I love that breakdown that you just laid out, Dr. Kane. So essentially, the main three types of repairs, as you mentioned, are the all inside, the inside out, and the outside in. And kind of breaking them down one by one in a little bit more depth.
Oh.
From the all inside repair, I've heard that the all inside repair, at least from what I've heard from different surgeons, tends to be a little bit shorter surgical time, and it tends to be a little bit quicker. And they really like that because it shortens the patient's tourniquet time. So they're typically in a little bit less pain afterwards compared to someone with a higher tourniquet time. Do you tend to see that hold true in your practice?
Yes and no, though. I think you really have to be careful with that because tourniquet time, yeah, that's important, but I don't think it's good to say that you should do something just because it's quicker, just because it's quicker does not mean it's better. So if you have a big tear and you try to get away with just doing an all inside technique where you maybe only use 2 or 3 sutures, are you really doing that meniscus or that patient justice when you really should take the extra time to do a proper repair and put more points of fixation in there? The other thing too is when you look at an all inside repair, the devices that are used for that, they're bigger. They have a bigger diameter, so they're making bigger holes through the meniscus. And every time you go in there with an implant, you're potentially creating a stress riser where you could re-tear through that meniscus. So, when we are able to put a ton of sutures in, those needles are really tiny. Most of them only 0.9 millimeters versus you're looking at some of the implants on an all inside repair, you're up to like 2.4 millimeters. And I was not good with math or geometry, but that stress riser, it's almost like, pi r squared. Like the risk of damage goes up significantly as you increase the diameter of the devices that you're using. So, quicker is not always better. You have to be good before you can be fast. And I think, yes, for sure. For some of the smaller tears, it's great. I think all inside repairs are awesome for the tears that they're indicated for. You don't need an extra assistant, which is nice. And it does save a lot of time in the operating room. But again, quicker is not always better. And, we talked about the inside out, repairs. You have to be careful of the neurovascular structures. Well, when you're doing those approaches, yes, you have to be careful of them, but just because you're doing all inside technique doesn't mean they're not at risk as well. So just because you're not looking at the nerves or the vessels or anything like that doesn't mean that you can't hit those with an all inside device. So it's something you have to be very, very careful for. You're careful with. There's pluses and minuses to all the different repair techniques. And again, I think it's really the tear pattern that dictates which one's the appropriate one to use. Again, sometimes you'll get really complex radial tears that just putting 1 or 2 all inside devices in there, that's not going to cut it. It's going to fail. And sometimes you could get a lot of different repair configurations if you go back to the old standard of inside out technique to do it. The thing I will say is there's a little bit of I don't want to say innovation with all inside repairs. Like in the past, the devices that we used had a high tendency for failure, for breakage, and it would actually cause significant chondral injury. Now the implants have gotten a lot better and we're able to use those, but there's actually still now indications for all inside repair where we don't use any implants. It's all suture based. So we're able to actually tie knots in the knee. There's different, devices that really don't leave any implants in there. So for example, going back to the types of different tears that we have, the horizontal cleavage tears, that's where the meniscus kind of split into a top and a bottom half. Traditionally, they have not been good to heal. We've tried different repair techniques and none of them have really worked very well. Well, now, we're able to kind of tie those. I call it like a hay bale configuration where we're actually able to use some suture passers and do an all suture-based repair and could get pretty good compression and pretty good healing rates with those, where it's traditionally in the past, they've been considered, oh, they're not going to heal. That always gets, 100% partial meniscectomy or a subtotal meniscectomy. Before you can kind of focus, just take the bottom leaflet out or the top leaflet out of a horizontal tear or take them both out. Now we actually have, techniques that we can fix them. Same thing if we go to the lateral side. There's sometimes some tears that are getting close to a structure on the lateral part of the knee called the popliteus or the popliteal tendon. We really don't want to go through the meniscus with an all-inside device and tether that lateral meniscus to that tendon. And that's exactly what an all-inside device in that section of the meniscus would do. The lateral meniscus has up to 1 centimeter of excursion when you're going through knee range of motion. So it's typically a very mobile structure. So it's not going to like being tethered to that popliteus tendon. So again, a new method of doing an all inside repair there is suture based, where you're not going through the popliteal tendon at all. You're kind of staying just within the meniscus, but still getting that compression, getting the synovial fluid out at the site of the repair to get it back together in approximation and to get it to heal.
In summary, the shorter surgeries does not always mean it's a better surgery. We really have to focus on the quality of the procedure and matching the right intervention from a surgical standpoint to the right patient and right type of tear pattern, as you mentioned. And I think it's interesting that you kind of brought up the whole implanted device round here, because a number of the repairs I've seen clinically have been more of like a suture-based type repair. When you say implanted devices, are you referring to like screw type things or other types of hardware that we might use to better fixate the meniscus or hold the meniscus together? Or what types of devices do you typically see used?
Yeah, so there's a lot on the market. A lot of them for these all inside devices. And I don't think anyone's seeing me off this podcast, so I could probably like use names and stuff. But one of the more popular implants, and there's a ton, and each device company has their own. But Smith and Nephew is a pretty popular one. They make a fast fix device. So that is kind of two implants. They're tiny, tiny, tiny little plastic pledgets. So you pop through the meniscus, and again, a video or picture's worth 1,000 words. You can watch how it's used, but you kind of pop through the meniscus, you deploy the device. So it goes in as like a skinny piece, and then you flip it so it catches on the back of the meniscus. That has suture that then connects to another one of those same devices. You deploy that, flip it, and catches, and then you kind of tension it, and there's a kind of knot tied in between the two, right? So there's a tiny, tiny, tiny little piece of plastic on each end of there. So that's the implant that I'm referring to, and most of the devices on the market have something extremely similar to that. One of the other big companies, Arthrex, they don't have any plastic to it, but it's all suture based, but it's a big wad of suture that goes in the back of the knee or in the back of the meniscus when we do the same thing. So they're the kind of implants I'm talking about. When we talk about some other different repairs, yes, we can use what's called anchors, but that's usually more for like we'll get in like root tears. So it's not going in the knee itself. That's kind of on the tibia through a tunnel. But no, most of the all inside devices, they used to be called like darts or something like that, but it's suture, but there's usually something attached to the end of the suture so that anchors it to the meniscus, and that's how you get the fixation for the repair.
You also mentioned earlier about the possibility of re-tear if the repair is not strong enough to hold. And it sounds like, based on what you were saying before, that's more common amongst like primarily suture-based repairs or repairs where excess material is used and the meniscus is damaged to a higher degree. I guess I gotta ask, how do you go about balancing how much to use on the repair versus not enough to use on the repair to make sure it holds?
Yeah, that's a good question. I think that's where it's kind of more of like an art form, not necessarily science, to be honest with you. And I don't know if there's a right answer. I think, again, that's kind of the frustrating but fun part of meniscal repairs. There's no tear, no two tears are the same, so it really is based on what the tear looks like and what kind of fixation you need for it, and it's a balance. You don't want to just shove a million sutures in there, but in general, especially with the inside out repairs, it's a very, very small footprint, so you get more points of fixation. A lot of times the enemy to healing is synovial fluid, to be honest with you. That'll get at the site of the tear or the repair, and if there's a lot of synovial fluid, that meniscus is never going to heal back down. So we're really trying to create a seal. So we're trying to really reapproximate. It's almost like fixing a fracture. So we go back to just basic orthopedics, bricks and a broken bone. It's kind of like putting a jigsaw puzzle back together. So we're trying to recreate the anatomy before the tear happened. And whatever method you need to do that, it's different for every tear. It's just, I think, again, going back to that toolbox, it's just you need to have a bunch of options available. And it's really based on, what that tear pattern dictates. And when you get in there, you never know. An MRI is a great screening tool. And I know you talked about diagnosis, and it really does help to tell what is it torn or not. And it gives you an idea of the tear pattern, but you never know until you actually look at the meniscus firsthand with the scope, what it's going to look like and what type of tear you're going to get and what kind of repair it's going to need.
I like that a lot. And, to that point too, it really is an art. And we see the same thing from a rehab standpoint, right? Like I might get one guy after a meniscus repair and, almost pain-free, just crushing it, and quad comes back super quick, and, we're just progressing nice and easy. And I might get someone else who the knee's just really, really puffy and swollen, and our approach has to be a little different for each of them. So, on both sides, the surgical side and the rehab side, I definitely agree that sometimes it is a little bit of an art form, and it's not really something we can just, up and put in words right away, or at least I can't yet. It's one of those things that we really just have to modify what we do to the patient in front of us at the end of the day. I also saw some literature that said the all inside repair is primarily used for more posterior horn type tears of the meniscus. Do you typically use it for that posterior aspect as well, or are you using it more for a tear in like the body of the meniscus? Or
No, I tend to agree. I think that's where most of us do use those is in the posterior horn. Again, you never know what the tear is going to dictate, but in general, even the mid body or like coming more towards the middle portion of the meniscus, I'd still consider it a all inside device. But if you're getting to need to use like a lot of them, one is cost. They're not cheap, and I know you need to just use what you need to use to get the patient a good repair, but you do have to be a little bit cost conscious. But it's really though becomes if you're poking a million holes in that meniscus, you do have to be careful about stress risers for that thing re-tearing. And if you're getting to the point where you're having to use a lot of devices, I think you really do need to consider at that point, like, Mal, this may be better fixed with an inside out repair. Again, going back, sometimes the old ways are the best. And we do have innovation and we're getting better with some stuff. But when you do the inside out repair and really take the time to put a lot of points of fixation in there, I think it gives for a stronger repair. And then it allows to, and we'll get maybe later with the rehab part of it, I think it allows sometimes for a stronger repair that can maybe allow for earlier weight bearing. If you're holding on with tenuous fixation and they start to weight bear early, that thing's probably going to re-tear pretty quickly. Versus if you give them a robust repair, I think it's almost like rotator cuff too. Like if it depends on the strength of the repair, size of the tear, and how many tendons involved. Same thing with the meniscus. I think it really dictates, rehab in terms of how good do you feel about that repair leaving the operating room. Did you put a lot in there, felt really stable to the probe, or are you like praying that person doesn't sneeze and cough in the Pacquiao and it pops right away?
I like that analogy. And, to your point from earlier too, you mentioned that the inside out repair is the gold standard and it is the strongest repair. On that repair, I've heard or seen some surgeons prefer a absorbable suture and some prefer a non-absorbable suture for their inside out repairs. Do you have a preference between the two? Or, for those who might not know the difference, what exactly do you mean by absorbable versus non-absorbable suture for an inside out repair?
Yeah, so absorbable, it sounds like what it sounds like, over time your body will kind of take care of that and the suture will dissolve and go away. I tend to not appreciate those. I don't think they have the best tensile strength. And a lot of times when we're doing these sutures come on really, really long needles, so we can pass them, and then our assistant who's holding that spoon retractor can find the needle and pull it out. I really am super happy. Again, with one of the companies called Arthrex, they have what's called suture tape. So it's suture, it's non-absorbable, but it's a kind of like almost like flat ribbon. It is really strong, which is awesome. Like you can almost pull a car with it. Like when you're tying, like I come home and I have, suture tape cuts on my pinkies, when you're tying, it's just really durable. I don't think there's anything more frustrating than if you do this great job of like passing these needles, you got this suture exactly where you want it, and then you or your assistant goes to tie the knot, because we have to get that suture, tight somehow. So we got to tie knots, right? So if you go there and then all of a sudden the suture just breaks, man, that is so frustrating. You just want to start like, oh, it's rough because you got to do the whole thing all over again because the suture doesn't even count. So, the absorbable suture, I don't really think is used too commonly. Sometimes for those outside in repairs, we'll see it because the anterior horn of the meniscus doesn't see the same kind of loads as the posterior and the mid body. And that has traditionally been done that way for the outside in technique, which without going into specifics, we kind of pass that suture through these like little needles or cannulas and then have to retrieve them. So to do that, you need a suture that's a little bit more rigid. And that traditionally we've used in the past is something called PDS, which looks like fishing line. So that does dissolve. But in the anterior horn, it doesn't seem to be a problem. But it is not that good when you're trying to knot tie, and it'll absorb and then break and then your repair fails. So I tend to use non-absorbable. And, with those types of sutures, particularly with the inside out technique, you're really not getting much suture in the knee at all. Like you can hardly see it. Like it goes into a little tiny sliver of the meniscus and then right at the capsule. So there's no real worry about the suture hurting the cartilage. All the knots are outside the knee, so there's really no reason not to use non-absorbable, in my opinion. I think it just leads to a stronger repair, and you don't have to worry about it, and you can handle the suture much easier.
No, I like that. I like that. That makes a lot of sense. Is at the end of the day, as you mentioned earlier, you want to do the surgery once and not have to go in again. And if you do it right the first time with, something that's strong enough and hopefully going to hold, hopefully there's no need for a second intervention in 5 years, 10 years, or maybe even longer. So I am all for the approach that, offers the best strength to the repair and hopefully minimizes, a need to go in a second time. You also mentioned before about, occasionally with the inside out, we might have to do a additional incision. And you said that that would vary based on if it's a medial or lateral meniscus tear, if I'm remembering correctly, like where the additional incision is going to be.
Correct. Yep. So yeah, again, we're doing that so we can protect the neurovascular structure. So on the medial side, we're going between an interval. We're using what's called the medial head of the gastroc in the back, and the semimembranosus, so one of our hamstring tendons down on the bottom. And then we put the spoon kind of in that little triangle, so the capsule's in front of it. We were trying to protect the saphenous nerve, so they don't get postoperative neuropathy or issues with the saphenous nerve. So that's the medial side, and then the lateral side, where it's kind of splitting the IT band, going right in front of the hamstring tendons and protecting that peroneal nerve. So again, we don't hurt that with the needles, and they don't get a foot drop. So that is, I won't lie, it is. I think it's a skill that as more and more people are doing all inside repairs, because a lot of them, my go-to is an all inside. I'm not gonna lie. Like if it's a nice, easy repair, all inside 100%. But I still think, buck and handle tears, big tears, complex tears, it really does dictate that you need the inside out repairs. But as more and more, I think trainees and people coming up just see all inside. The art form of doing the all inside technique is getting lost a little bit. And I think it's a shame, because I really think it's essential. For some tears, they really just dictate that you need to do that extra incision on the inside or outside of the knee. And you just get a better repair. But it's important to make those incisions. So a lot of people maybe don't because they're afraid or they don't want to make that incision. Incisions heal, it's going to be a little bit of a scar, but would you rather that or have a nerve injury? So, I think if you don't make that incision and you just start passing these needles, you're like, oh, we'll be okay. You're going to increase your risk that you're going to hit something that you shouldn't. So I think it's really important to use these retractors and make these safety incisions, so you don't run into those issues. You can't avoid a problem, you got to prevent it. So I think it's really important to take the time, learn the anatomy. If you're not comfortable doing it, I don't know how many surgeons I'm talking to on this podcast, but you just kind of take the time to learn either in a cadaver course or something, because I think it's an art form that you really need to have in your toolbox. Again, going back to that toolbox, you need to have that available, because some tears really dictate that type of a repair.
Yeah, no, definitely. And ultimately, at the end of the day, we're all trying to serve the patient at the best of our ability. So taking the time to learn those different things and expand your toolbox and learn when to use what kind of tool. And I'd imagine, from your eyes, it kind of becomes almost like a clinical judgment thing sometimes, right? Like you probably get like a gut feeling with certain types of tears or certain patients, like, I just feel like I should go with this approach instead of that approach. Like, maybe you see a complex bucket handle and you're like, I could do an all inside and it would probably hold, but my gut tells me I should do it inside out because it's a stronger repair.
Yeah, completely agree. And there's a lot that goes into that. Again, when you look at the tear, when you get in there, I think you have an idea from the MRI. So yeah, if I know it's a bucket handle tear, I have a pretty low threshold and I'm going to do an inside out, but not always, and a lot of things come into play too. What other concomitant injuries or surgeries you're doing? What does the articular cartilage look like? Because again, we're pushing repair, and I definitely, try to push the envelope and repair a lot. But if it's a tear and they have, horrible arthritis, we're not doing that. That's probably the wrong surgery. They're not really a candidate for a repair, right? So I think you do have an idea going into it, but you never know until you get in there. And a lot of factors influence what type of repair you're going to use.
You also mentioned about the outside in repair a few different times, and I don't really think I see many of those clinically. You mentioned that it's more of a repair we use for the anterior horn of the meniscus, and as you alluded to, we tend to see very few tears in the anterior horn, or at least I do. A lot of the tears in the meniscus I see are usually either in conjunction with an ACL, as we mentioned before, with that valgus moment, high force, either contact or non-contact, or in a deep knee bend and rotation type of pattern. And when I see that, mechanically, that's more of a posterior horn biased compression and force on the meniscus. We're not getting nearly as much in the anterior horn. I guess if I was going to see an anterior horn tear, I'd expect it to be more of like an extension biased injury than a flexion biased injury.
Yeah, yeah, I completely agree. I mean, it's really not that common. It's way more posterior horn and mid body tears. But you're right. A lot of times we'll see, particularly the lateral meniscus in athletes. Sometimes they'll have a hyperextension injury or land on an extended knee, maybe feel a pop. ACL is fine, but then you get a radial split at the junction of the anterior horn and mid body. I think that's probably one of the more common scenarios that we see. And it's not nearly as common, but yeah, the anterior horn, just because of, like you said, the femoral rollback and like compression forces on the posterior horn, way, way, way more common. But you do still, again, see tears. And going back to that toolbox is just another way, because you never know what you're going to see. It's just another way that we can fix those types of tears that you need to know, because sometimes you get in there and you're like, oh, I'm going to fix you're a hammer, everything's a nail. I'm going to fix everything the same way. I'm going to use an all inside device for every single meniscus repair. Well, you might not be able to reach it. Like the angle, it's really in front of you. So you're almost like working backwards on yourself, that you really can't get the correct angle. They've kind of changed a few things where now we do have some options we didn't have before. We have one all inside device that we can bend a lot. So we can almost make like a pretty steep curve and hit the anterior horn. That one's a nice option that we didn't have before. We also have for the inside out repair. I know that's typically more in the back, but we now have these kind of what we call zone specific cannulas. So ways that we can bend those really long flimsy needles to get to the very front of the tear. But even then, it doesn't always work. Sometimes it's a really anterior tear and you have to do that outside in technique.
Right. And as you mentioned earlier, that outside in technique means we're going from the outside of the knee into the knee with our repair.
Correct. Yeah, you're kind of poking through with these what we call 18 gauge spinal needles or whatever type of needle that has a hole in the middle. So we poke through, we can remove the little stylet that's inside the needle, and then there's a needle that's a hole. We kind of use them as like a spear almost. And then it's you do that twice, and then one of the needles you put this little kind of snare trap in there. So it's almost like kind of like the claw game at the arcade. You're like kind of just retrieving suture, and then you have this kind of looped suture that then you make an incision and tie over the capsule. But the way that you're kind of approaching the meniscus, you're doing it, like you said, from the outside in instead of the inside out.
Yeah, definitely. I like
A
that.
video, I think, yeah, video would be easier than me trying to explain it, but yeah, just a different way to do it.
We're gonna have to get you a social media channel and you can put some videos
Oh
up
God,
of these
yeah,
different repairs, Dr. Kane.
that's scary, but yeah.
I don't think I've ever seen one clinically, but I know one or two other clinicians that have actually seen a open type of meniscus repair. Is that anything that's really common practice at this point, Dr. Kane?
So, I think it's kind of hard. What's the terminology? Are they calling an inside out repair with that extra incision an open repair? I don't know. I mean, an open repair, like with an arthrotomy, like through the knee, like where you open the knee up completely, that's really not done much anymore. Occasionally we'll see someone who comes in with a lateral tibial plateau fracture. A lot of times you're there putting a plate on, and you'll do a meniscus repair at the same time. And a lot of the plates for a tibial plateau have little holes at the very top for suture. So, that is one instance where we still do see like a really truly open arthrotomy, but I kind of think maybe they were referring to an inside out repair. And again, because it's just not, I think it's not done as frequently as maybe it should be, or it was in the past, because we have all these all inside devices that even some maybe therapists or people that aren't familiar, they're calling some inside out repairs open repairs when they're really not. It's still arthroscopic, but it's just how we do it, But there are very, very rarely some instances with a truly open repair, but they're few and far between in 2024.
You also mentioned before about the root tears. And the root tears are something I've found to be very complex. And, our little phrase lately has been, you really only get one shot to do it right and one shot for it to hold. If you re-tear a root tear, that's a very complicated situation to find yourself in. So you mentioned before you do it through the transtibial tunnel. It's funny because every time I see a root tear, it's in conjunction with an ACL tear. I'm not sure if there's a strong correlation there, but We take it a lot slower from a rehab standpoint initially. I usually don't get people weight bearing at all in the first month. Sometimes we even wait closer to the 6 week mark, and in one case, 8 weeks. Just depending on the type of tear, depending on what exactly the surgeon saw when they were in there. This is one area where I really, really tread slow.
Yeah, I think root tears, again, they've been around. They're not new. We just, I think, are becoming more aware of what they are and what their consequences are over the last decade or so. To kind of break them out in general, medial root tears, a lot of times we see those in the 40, 50-year-olds. They're the ones that kind of got out of the car, twisted, felt a pop, and they have medial-sided pain. And they're a little bit more on the degenerative type spectrum, whereas the lateral meniscal root tears are way more common in the younger athlete with an ACL tear. It's estimated that up to 1 in every 7 ACL tears also has a lateral meniscus root tear. So again, this is the kind of thing that they've seen us, but we may not have seen it. But I think we're becoming more aware, and they also aware of the consequences of a root. When you have a root tear, they've done a lot of studies where they show they do like pressure sensor mapping in the affected compartment. And when you have a root tear, it's almost like you've had a subtotal meniscectomy, meaning you have no meniscus at all, because that meniscus can't do its job of transmitting that load to the tibia because it doesn't have that anchor point. And then what happens is the meniscus gets extruded. So I give the analogy of like, you cut the top off a banana and step on the peel, and the banana is now squirted out. Like, it's not in the joint. It's not doing what it needs to do. So, the lateral meniscal root tears are way, way, way more common with ACLs, but the medial meniscal roots we still see, and we tend to still recommend fixing, but they're different. I think for the meniscal roots on the medial side, we really have to take into account a couple of factors. The cartilage status of that compartment is really big. So we see them a lot of times, maybe in a little bit older patients, but if they have really bad arthritis, they're really not a candidate for repair.
No, that's a great point. Going back to what we talked about initially on the acute versus degenerative tear, the later stage tears are certainly ones I tend to see different surgical approaches used compared to the younger ones, where preservation tends to be the goal with the repair. You mentioned the transtibial tunnel, and we talked a little bit about how the lateral meniscus root tear in general is more common with the younger ACL. Are you able to do the tunnel through the same incisions you would do for your ACL graft, and ACL surgery and tunnels that way, or do you have to do extra incisions on top of the ACL reconstruction, incisions themselves?
Sure. So, my mentor, Dr. Leprot, would kill me if I don't answer this correctly. This is one that I would think if you just go back and look at the anatomy, there is no possible way that you are recreating the anatomy of that lateral meniscal root if you're putting it through one tunnel. I know some people might try to debate that and cut corners, because it is. It's way more convenient if you try to just make one tunnel, because if you're doing a separate root tunnel, you do have to worry about the risk of what we call convergence. So those tunnels colliding with each other. But if you try to squeeze a root tunnel into the ACL tunnel, you're doing one of two things, or most likely both. You're putting the lateral meniscal root attachment way too anterior, and you're putting the ACL tunnel way too posterior. If you really look at the cadaveric dissections, they're almost a centimeter away from each other. So to try to recreate the anatomy of both of those correctly through one tunnel, you can't do that. It's impossible. So I personally think and strongly recommend two tunnels. The ACL tunnel has to be separate from the lateral meniscal root tunnel, because again, we're trying to recreate anatomy. And if you're putting that tunnel in the wrong spot, you're not restoring that meniscal function, and it's not going to work.
Yeah, no, exactly. And to that point as well, I believe a very high contributing factor to ACL reconstruction failure rate is incorrect tunnel placement. So if you don't get the anatomy right, the ACL could re-tear, or it's at increased risk of re-tear a second time. And, that's something going through it once is bad, but going through it twice or possibly even 3 times can be really debilitating or career ending for some athletes. So getting that tunnel placement right. And as you mentioned too, it's just as important for the root repair, because if that repair doesn't hold and the meniscus is not functioning as it should, I love the analogy you gave of the banana. Like, we're literally just adding insult to injury at that point. So I'm a very big believer and fan of getting it right the first time and hopefully avoiding a need for anything again in the future.
Yeah, and I think the most important part is trying to put back what you had before you got injured. And if you're not going to do that and you're going to do a non-anatomic repair, you're not doing what you should, and it's not going to work. And in particularly these young athletes with ACL tears, in the lateral compartment in particular, they can go on to pretty devastating osteoarthritis pretty quickly. It's already a risk from the injury, but if you give them a non-functional lateral meniscus because you put the root in the wrong spot or the root re-tears, they can get grade 4 cartilage changes, unfortunately, early in life, and then there's really not a great option for them.
Yeah, and unfortunately, I've seen that clinically, and it's a really weird conversation to have with an athlete in their late teens or 20s, even sometimes, about cartilage defect and options for cartilage and joint preservation long term, right? And that's where things like the Oates and the Macy procedures come in and that sort of thing. But if we could avoid the need for secondary procedures to maintain articular cartilage in the joint, then why don't we? You brought up an interesting point earlier too that I really want to ask you, because I've seen a couple repairs where they do anchor to that popliteus muscle. And I've noticed that individuals that have a repair there tend to be in a lot more pain. So if you're looking at a meniscus tear, what would lead you to, decide I'm going to anchor this tear to, the popliteus muscle or tendon? What kind of tear would it be, and why would you choose to do that? And what kind of, device would you use to anchor it there? Or, would there be some kind of alternative anchor option other than the popliteus?
Yeah, well, I would personally try not to anchor it there. I think that's the main goal, is because we don't want to, because I do think it's not supposed to be tethered like that. The lateral meniscus has a lot of mobility and excursion, and then you tack it down to this popliteal structure, which is also a dynamic structure. I just think it adds for a lot of pain, and there's going to be over constraint, and you're going to have problems with healing. So I really, each tear, again, going back to that, it's different. So it's hard to give a general statement, but if you're going to do an all-inside device or all-inside repair, try to not go into the popliteus. Try to look at that tendon, go either right next to it or right, on either side of it. Or if you have a tear that dictates that it needs fixation where that tendon is, they do have all-inside options now where you could take a suture passer and then just try to tie knots in that meniscal tear. In general, we worry about knots in the joint because we don't want it to hurt the cartilage, but more often than not, you can try to push that knot stack away from the cartilage, and it undergoes a process called synovialization. So it kind of gets scarred over, so it's not this like prominent knot stack. Or going back to do an inside out repair, because you can angle the needles and you can kind of do a different type of repair to try to avoid tethering it to the popliteus. And then just real quick, going back to your point before about the cartilage changes and not repairing it. Well, I think the other thing that's really important pertains to the lateral root is vigilance. Again, you have to look for these. It's estimated that almost 1 in 7 ACLs has a lateral meniscus root tear. So they're there. So if you're not seeing lateral meniscal root tears when you're doing ACL reconstructions, you're not probing that lateral meniscus root, you're going to miss some. And then, they're going to have issues with that later. They're not always picked up on MRI. So MRIs are great. They can tell us a lot of information, but the sensitivity of an MRI picking up a lateral meniscus root tear, it's not 100%, so you really have to have awareness and look for these to really try to make sure you're not doing your risk and just trying to like stick your head in the sand and like, oh, it's fine, it's going to heal. It's not going to heal. You have to recreate that anatomy and do the repair.
No, I love that point. That is a great point. If you didn't look, then how do you know it's not involved? So I love that point. And, the other thing I hear a lot too is, with the ACL reconstruction, our meniscus repair, long-term outlook tends to be a little bit better because, we're drilling into bone. That tunnel is essentially going to soak the joint in the meniscus that you just repaired with all those different growth factors from the bone. But if there is something there that you didn't repair or address during the surgery, I'd imagine it's not going to just magically heal on its own, even when it's soaked in, a lot of biologic compounds from the bone tunnel itself. You still have to address whatever tear is present.
Yeah, yeah, I agree. And we can't ignore it. If it's torn, you got to put fixation in there to fix it.
It's interesting too, as you mentioned about, the dynamic nature of the lateral meniscus, because most people think of the meniscus as something stable, not something that moves around in the joint. But, when you think about the size of the knee and the amount of excursion it has, it moves around quite a bit in there. And there's different variants. Thankfully they're rare, but, the discoid meniscus comes to mind for me. Like, you have variants where that thing moves around a ton more because it's lacking, stabilization structures for one reason or another, in certain individuals. And in that case, I feel like, the importance of additional stabilization, becomes even more important because you've got something that was inherently unstable for, possibly an individual's entire life, before it was torn.
Yeah, no, I agree. The anatomy of the medial meniscus, it's different, it's wider, it's got more attachment sites to the, tibia. But yeah, you're right. That discoid meniscus, it can be pretty mobile. So it's kind of rare when I do see a discoid meniscus to just trim it. I'm almost always, not always, but almost always do what's called a saucerization and make it look more like a normal meniscus, but follow that with a repair. So yeah, it can have a lot of excursion, and I don't think it's meant to have that much in some of those variants, and it doesn't dictate repair.
On the rehab side, the way I usually approach meniscus repair, or really any post-op sports knee in general, is we always start with regaining extension motion first. And we really hammer that. And that's probably the most important thing from an ACL side as well, getting into that a bit. I think the ability to get the extension range of motion back quickly, really tells me a lot about how someone is going to progress for the rest of their rehab. And I don't just mean like passively being able to move them there. Like, I want someone to actively be able to squeeze their quad to the point where they can achieve open chain hyperextension or whatever their full knee extension is on their own. And it's a race to get that back. I don't really like to push the flexion too much early on because a lot of protocols actually restrict how far you should flex someone after repair. And I've found that pretty much every time, like I would say 95% of the time, we get within 3 to 5 degrees of full flexion range within 8 weeks, just going slow and steady with it and respecting tissue healing timelines. So extension first, hammer extension, hammer quad strength. Swelling control becomes huge. And, some of my patients laugh when I tell them this, but, we're going hours per day on the elevation and ankle pumps. Like, I tell people to do tens of thousands per day. We're icing 10 on, 15 on, 15 off, whatever interval suits you best, but we're doing a lot of ice early on to try and bring the effusion down. And I think that if you can start the first 6 to 8 weeks with getting full extension range, slow and steadily increasing pain-free flexion range, hammer the quad strength, and get the effusion down, the rest of your rehab is really going to fall into place pretty quickly.
I completely agree. It's always, I have that constant struggle, and I try to hammer with these patients, don't put a pillow under your knee. It's going to feel better. Put that pillow on your knee. Like, don't do it. Put it under your heel. Like, I cannot agree more. Full extension. You're not going to hurt any meniscal repairs in full extension. That meniscus is really not getting loaded much. And if you have any type of flexion contraction, once you do start to put weight on it, it's a mess. Your gait mechanics are all off. It's really hard to regain, like, come back from that. And I agree with you. I think the flexion, it depends what other maybe procedures you're doing with the knee, if you have, other injuries or something, but you generally do, I think, tend to get that flexion back. I don't worry about that. I completely agree with you. I worry about the extension, and I do the same. I really try to hammer, get it fully straight, get it fully straight. Don't let that quad atrophy, get the swelling down. I think just like not all tears are the same and you need a toolbox to do all the repairs, I don't think all meniscal repair rehabs are the same either. I think I really try to keep an open dialogue, and I give all my patients their physical therapy prescriptions, but I really try to be descriptive and write what type of tear they had, what type of repair we did. I have different rehab protocols, and for roots, ramps, radial tears, all that kind of stuff. There's little nuances to it, but in general, I agree with you. I actually restrict most repairs of mine 0 to 90 degrees of flexion for the first 2 weeks because we don't want to do more rollback. And when I do my repairs, when I'm tying sutures or putting the implants in for a root repair, I tend to do that at 90. So I know the repair is stable through that arc of motion from 0 to 90. But yeah, I don't go crazy aggressive with the flexion. And then even with the root tears and a lot of the repairs too, particularly like complex radial tears, I really try to limit weighted knee flexion. I really try not to go past 70 degrees for almost up to 6 months in really bad ones. So yeah, I agree with you. Extension all day long, flexion will get that back. I go slow with that. And the weight bearing is different. There's differing opinions. And it depends on the strength of the repair, the size of the tear, whether or not you're doing it in conjunction with an ACL reconstruction. Some have accelerated rehab protocols for weight bearing. But the tear pattern dictates that. Most of the literature shows a lot of the root tears in particular. If you try to advance your weight bearing quicker than 4 to 6 weeks, your risk of failure goes up. Now, sometimes, a very stable repair that you did, bucket or not, or if you have a ton of fixation points with inside out technique and they had an ACL done at the same time, maybe you can start to load them a little bit earlier. But I think, again, it's dictated or predicated upon the repair that you get. And I think open dialogue with the therapist is crucial. I really try. Any questions I have them call me. I write all the stuff down that we did. Sometimes I try to include an operative report if I can. So it gives, the therapist a better idea of what did we do in there.
And that just goes to the point of the importance of communication between the PT or rehab specialist and the surgeon, because, every tear, every patient is different. So if you don't have that communication back and forth, or if you don't pick up on little things that go wrong, like say someone starts to develop like a meniscus type pain in their rehab, like, I'm getting on the phone and I'm calling the surgeon or texting the surgeon like that day. Like, there's certain things we don't like to see. So, having that communication back and forth is essential. In general, most of the repairs that I see, we're restricting, to your point about restricting flexion closed chain. I'm usually not going past about 90 degrees for about 3 to 4 months. Even if they can do it, even if they can, move past it, I'm not going to load them in those positions, because why would I risk, someone who's progressing well, why would I risk them re-tearing in PT of all places, just so I can load them a little bit more in a little bit of a deeper angle, right? Like, I can get everything I need initially from a closed chain standpoint, 0 to 90. I think you look at the timelines for meniscus return to playing, we're looking 6 to 8 months. So I have plenty of time to get someone back. I don't need to force them into full range, cheek to grass type of like barbell back squat here. Like, we don't need to get in that range at the 10-week mark or the 12-week mark. I'm a huge fan of squatting to a box, and I will measure the height of the box that I use and measure the knee flexion angle that the patient has at that point before we load, as a way to, incorporate higher loads. I think that lifting heavy should be a part of rehab for athletes, but there is a safe way to do it. We also just got a yoke in our Salisbury location, and some people are going to say, why the heck do you need a strongman yoke in PT? But when you stop and think about it, we're essentially carrying a high load, but we're walking with it. So we're not getting much knee flexion at all there, but we're able to load the entire system with hundreds and hundreds of pounds of weight safely. So I can get that overload effect without really putting anyone in a position that would risk any type of injury to the meniscus. So, I think that there are a lot of great ways to load patients following a meniscus repair safely. And I think that could probably be a podcast episode in its own. There's another thing I've shied away from, and maybe this is just my own, still learning kind of process here, but anatomically with medial meniscus tears, you mentioned the semimembranosus muscle earlier, and that tendon, I believe, attaches right onto the medial meniscus. So I actually don't go crazy with the hamstring work, especially open chain, early on in the early and even early mid phases of meniscus rehab with patients. I really hammer the quad heavily, and I get the hamstring back. We make sure we have good ratios and we test all that, but that's not really an early priority for me, just due to the anatomical consideration of semi-M tendon and the medial meniscus.
Yeah, honestly, to hear you say all that stuff is so refreshing, and I wish all therapists thought the same way you do to make my life a little bit easier. But no, I completely agree with everything you said. I wish people wouldn't go nuts on like going, like you said, cheek to grass and focusing on that, because you don't need to do that. That's going to come later. And I do think some of it is setting expectations. Again, apples to oranges. I think people are like, oh, I'm just getting my knee scoped and taking my meniscus, getting cleaned out or whatever, and they're back in 6 weeks. To your point, I think really doing it right, return to sport, 6 months minimum for me, and I say that up front. So I think just to paint their expectations, so you do kind of set those realistic goals and those time frames, so you're not loading it. I agree with you too with the semimembranosus. Again, it depends on where the tear is. It's kind of right at that junction, posterior horn mid body. So yeah, if you're kind of getting close with some of your sutures or your implants, or it can pull on that. So yeah, I do agree. And I don't feel like the hamstrings are hard to get back. I feel like it's all quad all the time, and it's just focused on that from day one and extension. And I think everything else, like you said, falls into place. I think it follows suit as long as you take care of that stuff first.
I completely agree. And, on that return to play element real quick, I know a lot of individuals who don't test at all before they discharge someone. And to me, that's a huge disservice to the person in front of you. How are you discharging them if you didn't test anything? And, with the technological advancements we have in rehab now, you can get some type of dynamometer or load cell for like $200-300. You
Yeah.
can get a pretty quick and dirty hamstring and quad ratio calculation and, get multi-angle measurements of quad strength and hamstring strength pretty easily and pretty quickly at, a very small cost. So I'm a huge fan of doing that. On the plyo side, I think most rehab professionals are familiar with, your single leg hop, your triple hop, your crossover hop. I like those, but I have fallen in love with the vertical jump. So I literally put someone on a vertical jump mat, and we do double leg vertical, and then we do single leg, left and right. And I like that better because in order to jump up, you really have to load that knee, right? Like you have
Yeah.
to bend forward and get more of a shin angle. I've
Yep.
seen some people compensate in crazy ways when they hop, and they don't load their knee much at all on the jump. They will on the landing, but sometimes those landings look a little sketchy or shady. I think the single leg vertical holds a lot of value in determining how well someone can load that knee and how much power they have. I don't think the body is going to let you jump higher than it feels comfortable absorbing that force from. So I love the single leg vertical. I also love the single leg squat. I mentioned before about the dynamometer and load cell. I think open chain quad is great and probably the gold standard still, but I also want to see how that thing functions. So I do a single leg squat just to a bench about 18 inches. I do left versus right, and I'm doing max reps body weight to see the endurance of it, but I'm also giving the patient a dumbbell, 50% body weight equivalent, and I'm looking to see max reps under that kind of load. And yeah, that's pretty heavy. That's a lot of force on the knee. But, if we're comfortable and confident that they're going to be issue free going back to sport, then I should be okay with them taking that amount of force. And if I'm not comfortable with that kind of test, then that probably tells me they're not ready to go back.
Yeah, I think that's super interesting. And, it's hard because I don't think there's nearly as much data on return to sport testing for meniscal repairs as there is. I'm just going to equate it to ACL. And
Yep.
that's what I use as a proxy, because we really don't have a lot of good data to guide us. So I use return to sport testing for ACL as kind of like a dirty extension of that, even though it's not really appropriate or capturing all meniscal repair patients, but it's the best I think that we have. So yes, I agree. I have patients make sure they have 90% quad strength compared to the contralateral side, and then I give them the ACL return to testing criteria. Is that great? I don't know. I think it's the best we have right now, because again, it goes back to the fact that there's so many different types of tears and so many different types of repairs. It's hard to standardize all that stuff, as opposed to an ACL. It's a little bit easier to we have better numbers to look at this stuff and we can standardize it. So I think all those points that you brought up, fantastic. I think it's really creative ways to think about going about return to sport testing. I think that's an area that we can potentially do a lot more research on and get more guidance for. But I agree. I do still test patients, but I just use the ACL stuff as an extension.
Yeah, I love that. I love that. And, to that point, I think the future with the incorporation of force plates and other, technological advancements is going to push the envelope on that return to play even further. But, I feel like we've covered so many amazing points and details relating to the meniscus injuries and meniscus repairs in general in today's episode, Dr. Kane. I really appreciate your time and everything you shared with us. Do you have any kind of closing thoughts or closing remarks or anything that we missed?
No, I think we covered a lot of it. Unfortunately, I think sometimes I'm a very visual learner, so I think some of these like surgeries or repair techniques and tear patterns, I think, I do better seeing them. So there's a ton of resources available online of videos and stuff like that. Or if anyone's interested, I'm sure I'll leave my contact info, and anyone on the podcast can get in touch with me. They can share any questions they may have. I think there's definitely a campaign to save the meniscus. So in the past, it's always been cut out. And sometimes we still have to do that. But I think with advances in repair techniques and rehab protocols and biologics and stuff like that, I think we can kind of push the envelope and achieve a lot of good repairs. They don't all work, but I think it's good to try, particularly in the younger patients where we really need that meniscus. I think if you're not doing a few takebacks for repair failures, because unfortunately they don't all work, I'm not going to stand here and pretend that every repair I do works. They just don't. But I think if you pick your patients appropriately, and again, use that toolbox to fit the repair type that you need for the tear type, and do what's best for the patient, and they do well with rehab and they're compliant, I think a lot of them do very well. And I think if you don't know how to fix these, or if you're interested, I think always great learning opportunities, because I do think, it's better for our patients if we're able to achieve a repair. And I think we can do that in the large majority of cases.
Completely agree. I love where your head is at, Dr. Kane. And I think that's one of the reasons, or one of the many reasons, you and I get along so well. For people who want to find out more about you, or, maybe they want to check out your clinical practice in Southern Delaware, where can they find you at?
Our, First Aid Orthopedics, our website. And then, I'm active with the AOSSM, so our American Orthopedic Sports Medicine Society. Serve a couple of hats there too, and try to participate. So if anyone's at any of the annual meetings, or just, want more information, you can get my contact there too.
Awesome. We'll link to those in the description below too. That way, if you want to get in contact with Dr. Kane in his office, you can do so there. It's funny. I thought you were going to say that you've got like a MySpace handle still or something like that.
Yeah, no, I'm old, but I don't know. I'm not very good with technology. I really don't take to social media, to be honest with you. I try to keep a low profile. Yeah.
Nothing wrong with that, Dr. Kane. I really appreciate your time and everything you shared with us today. This was amazing. Thank you.
No, thanks for having me. Appreciate the opportunity.